which was cross-sectional hospital study, the severity of the dry eye disease in moderate to severe cases was to the tune of almost 80%. But of course, all these cases were referred cases. So for the dry eye management, initially we do give lubricants, and it is only in the later stages that cyclosporin is added, mainly because it is dry eye is an inflammatory disease, and the vicious cycle has to be broken by the use of the cyclosporin, which prevents T cell from going into the uh, getting activated. So the concentration of almost all of the cyclosporins are oil based, and which decreases the bioavailability and causes stinging and burning sensation. And apart from this, they also have preservatives like benzalkonium, which may cause cytotoxic damage, increase breakup time, and also trabecular meshwork degeneration. So we do have aqueous-based formulation such as the Cyclysis PF, which is truly a preservative-free aqueous-based cyclosporin, and it is formulated with the NPL technology. NPL means novel proprietary lipid technology, which enhances the solubility and stabilizes the. It actually stabilizes the lipophilic cyclosporin, and the, in this technology, basically what happens is that it degrades so that it becomes more friendly to the surface. The lipid component is washed away along with the tears so that the cyclosporin can act on the ocular surface. And if we look at the cyclosporin concentration with this in conjunctiva and cornea, it is quite adequate. It is well tolerated, preservative free, and enhances the patient persistence with therapy as well. It is also being marketed in Novelia bottles, which is multi-dose eyedropper. And there are various studies to show that topical cyclosporin does work in dry eye patients because it decreases the tear breakup time. And even results of cyclosporin 0.05% have been found to be good. This was yet another study where role of this cyclosporin was seen, and it found that there were improvement in the parameters as far as the Schirmer's, the breakup time, and the OSDI is concerned, and this was also at the end of the 2 years. And this also was seen that goblet cell density did show a beneficial effect in these cases. So in after refractive surgery also it helps, although personally I do not give cyclosporin after LASIK surgery. We tend to give only topical steroids and topical antibiotics as well as lubricants. But it can be added in post-LASIK dry eye patients, as has been shown by some studies. And this is a little too far-fetched that you can also use it after cataract surgery. So, in a nutshell, cyclosporin, Cyclysis PF, which is almost preservative-free and is friendly to the surface, can be used in dry eye patients, and also perhaps can be used in LASIK surgery in case you do use cyclosporin following LASIK surgery. So, thank you very much for your kind attention. Thank you. Come. Intas makes it, and this was a commercial commitment. Yeah, so Intas makes it. It's good, actually. We are doing a study also on Cyclysis PAF, but we are yet to analyze our data. Like with other companies, they don't want us to compare with another cyclosporin this thing. They just want adjuvant role. And we are doing it we've now done close to 60 eyes, but our mandate was to do in cases of 100 eyes after LASIK surgery.
Patient tolerance is better to this drug.
Yeah. No, they do tolerate better, and we've incorporated ConfoScan, etc. also to see if there is any effect. We've not, I think I shouldn't be saying, I mean, this is another investigator-initiated trial where we're comparing rheostasis with cyclosporin.
One of the problems we face
PF.
with the patient is the cost. The
Yeah.
second thing is, sometimes if they get irritation with the drop, they discontinue it. So
Yeah.
because the beneficial effect is seen only when they use it for long term. But if the patient uses it for
Discontinues,
a short time,
then
so
it's
this
a,
is one drop where
at least they'll use it for some time. Okay, thank you.
while you'll argue to save time, I'll just continue because I am carrying colds to Newcastle over here, so I don't have to give any tips to this audience. But for the benefit of the projectionist, you might learn a little bit. So the options that we have in infective keratitis, surgical options are surgical debridement, AC wash if it's a fungal with M4. You can use tissue adhesives, you can use amniotic membranes. These are things, surgical things which have been tried. Of course, prevention is better than cure, which is said by everybody. So if there is an ulcer with imminent perforation, treat it as an emergency. If perforation occurs, restore the integrity ASAP by tissue adhesives is small, patch graft if peripheral, and AMT. And if you have tissue available, then of course penetrating keratoplasty, which will restore the structural integrity. It will resolve a refractory, if just nothing is working, at least you get rid of the load, reduce the organisms in the cornea to a manageable level. And if it's a central ulcer which is not healing, then you can even use an optical grade tissue if you get it, and it might be just a single time graft that you have to do. So it's an emergency. Why? Because perforation will increase the chances of end-off. Central corneal infections, as I said, you can get optical results. And if infection is not controlled, it might go on to the sclera, in which case it becomes extremely difficult to treat. The pre-op, of course, depending on what the scraping has shown, we will put the patient on topical antibiotics or antifungals. If possible, you can do a gentle B scan to rule out choroidal detachment. I prefer a general anesthesia when the patient is fit. Give realistic prognosis and keep the microbiology lab on alert. Donor material, in emergency we use whatever is available. If it's a central graft, good donor is always better, and I keep large trifines ready. You don't really know how large the donor is going to be, so you trifine the recipient first. Trephination in the recipient has difficulties. Hypotony makes trephination difficult, and therefore you might go too deep and injure the iris during the trephination. That is quite possible. And then even if you've just made the cut, we recommend obviously that you don't go full thickness through, just make a nice deep groove and then enter with a knife. But even cutting with scissors difficult, the corneal opacification hinders the view, and UVR lens IOL often come bulging forward. Vitreous may be adherent to cornea if it's an aphakic eye, so you need to cut very gently. So I normally mark the area with the trifine, cut with scissors. If there is already a perforation, start at the perforation site and then follow the groove. Use copious amounts of viscoelastic, cut the recipient cornea first, and peripheral iridectomy is essential. If the fistula is small, I will close with glue and then go ahead with trephination. Try and reform the chamber, use a good speculum. If the eye is soft, use a Fleringa ring. In fact, in all TPKs, it's good to use a Fleringa ring to prevent prolapse and the scleral prolapse, scleral collapse, and expulsive hemorrhage. And if you have access to Hesburg-Barron, that would be ideal, but otherwise just use whatever you have. After the recipient button is removed, inspect the AC for peripheral synechiae, posterior synechiae, cataracts. Look for inflammatory membrane. This is important that you, many a time in all these cases, there is a thin inflammatory membrane over the iris, and unless you look for it and sort of dig it out from there, you will leave behind a sort of a membrane over there, and the inflammation will continue. If possible, don't remove the cataract at the same sitting, because you get increased risk of expulsive hemorrhage, vitreous loss, endophthalmitis, and you can have the P. acnes or whatever organism getting sequestered in the bag. So if you can, please do it at the second sitting. And you normally tell the patient that you will require a second optical sitting. At that time, you can do the cataract surgery. After the recipient button is removed, irrigate the AC to remove the necrotic debris. Place copious viscoelastics in the angle. Try and open all the peripheral synechiae if possible. And I take at least 16 interrupted sutures, always interrupted sutures. 10-0 nylon, 75% depth. In a regular optical keratoplasty, you can go up to 90% depth. But in this, it is difficult, so 75% depth is quite adequate. Moderate amount of suture tension. Go further into the recipient bed to avoid cheese wiring. Reform the AC. Check all the synechiae are lysed and check the wound repeatedly for leaks. You can put fluorescein drop also if you like. If you're giving a subconjunctival in an antibiotic, in a the bacterial infection, you can give an antibiotic. Avoid a subconjunctival depot steroid if fungus is suspected. And if it's a small central ulcer completely removed, then you can of course give subconjunctival steroid.
VLC will take from the folder.
Yes, sir. It's disconnecting by itself actually. Bar.
No, the folder is there on which the video is there. You
Yeah,
can play
yeah.
the video
Yes, sir.
separately.
No, the pen drive disconnected by itself actually.
This is playing, it's not here.
Oh, it's not here.
I've forgotten how to do this.
सर ऑडियो है उसके अंदर
हाँ जी,
ऑडियो चाहिए
ऑडियो नहीं चाहिए इसमें. 1 second. Now it will work. गया.
Yeah.
Pen drive isn't showing now.
You can put this directly into this.
No sir,
Achha.
it doesn't have USB ports. It's connecting. It will take because the presentation also.
Actually, the video was embedded in it.
It's here. We can play it later, I guess, when it detects it.
Yeah.
Yes sir.
Playing?
Media not found.
Play it from the.
And connect it here. Should not happen. So normally works.
Okay. We'll go on with the PowerPoint and close.
Yes sir. Well, if it, yeah, it's come. I only have quick time. No, it won't work, sir.
Okay, let's just go ahead with the. Okay, so we'll just pretend that you all have seen a fantastic video of the therapeutic penetrating keratoplasty. Thank you so much. The common post-op complications are secondary glaucoma. We need to look at graft failure first in the first 1 month, and later on, of course, graft rejection and infection in the graft itself, which is commoner in fungal cases. Prognosis depends, of course, on the type and virulence of the organism and the type of treatment that you give post-surgery. Post-surgical care is challenging. When do you give steroids? So you can give steroids immediately after if you think you've removed almost all the bacterial. If it's fungal, I at least wait for about 3 to 4 weeks. Acanthamoeba also at least wait for about a month and put the patient on fortified topical whatever drug depending on your lab reports. If the sclera is involved, IV antibiotics, otherwise not required. Anti-glaucoma treatment prophylactically, and then as soon as possible measure the pressure. I use an eye keratometer by which you can measure from the next day itself. So thank you so much for your attention.
Sir, I have one question. Like, so a lot of times what happens in therapeutic is the lens is bulging out.
Yeah.
So, would you recommend doing a pars plana vitrectomy at that time, or just?
If you have somebody good who can do a pars plana vitrectomy and bring the bulge down, fine. Otherwise, if you use a Fleringer ring, if you give mannitol pre-op, and you use viscoelastics to tamp it down, you can normally get by without having the lens bulging up. But if you can't, and worst case scenario, then a pars plana vitrectomy by somebody who's trained in that, because otherwise you can get an expulsive on table. Yeah. Okay, thank you.
So thank you, Quresh sir, for this wonderful talk. Screen. Screen. Yeah. So my topic is optical PK and triple procedure. To introduce penetrating keratoplasty is a full thickness corneal transplantation. It has the longest healing time amongst all keratoplasties, and it has the highest chances of rejection as well. So if you look at this data, this study showed that actually penetrating keratoplasty made up to 79% of the cases of keratoplasty that were done in India. In these, and out of which, of the total, 47% was optical PK. The trend is changing now. We are moving. A lot of surgeons are now adapting lamellar surgeries, with which have much better results. But if you take India's example, we have a lot of infectious cases. We have a lot of corneal ulcers, a lot of trauma cases where there are full thickness scars where lamellar surgeries will not be able to do justice. So these are the indications of transplant for PK in the study. Again, a lot of these indications have reduced with the advent of lamellar surgeries, but microbial keratitis and corneal scars post-trauma and infection is what we generally do. Sorry. So there are four prognosis cases. You need to evaluate them. Category 1 being the excellent cases, having a 90% success rate. These includes keratoconus, lattice and granular corneal dystrophies, and early stages of Fuchs dystrophy. But category 2 would be the cases with very good prognosis. Category 3 with the ones would be having a fair prognosis, 50 to 80% success rate, and the poor prognosis cases, less than 50%, would be cases you don't want to touch, like a case of a Stevens-Johnson syndrome or a pemphigoid and neuroparalytic diseases, etc. So these are the contraindications, and SJS and severe dry eye stand out over there. Coming to the preoperative assessment, you need to assess the visual potential of the patient by the past best corrected visual acuity, the age of the insult, the ocular alignment or fixation or presence of squint, and the projection of rays. You need to assess the cornea for its size and depth of the scar and the vascularization, the anterior chamber for any pars or iris defects, the status of the lens, and any vitreous in the anterior chamber. You need to also evaluate the ocular surface for dry eyes and also look at the adnexa. Preoperative investigations, ASOCT is sometimes helpful in locating the depth and extent of the corneal pathology, the looking for thinning, looking for any retrocorneal membranes, and sometimes anatomy also it shows, and the endothelium IOL distance and the regularity of the anterior chamber and the stability of the IL. UBM can also be done, but one thing that you must do if you cannot see the fundus is the B scan. Preoperative biometry would include keratometry, which you have to assume, I generally assume around 44 to 45. I put this question to the panel as well. What is the keratometry that you assume in cases of for optical cases such as this?
For me, I use 43.
43.
44 is what I use. Same. Whatever you use,
Yes.
you have to tell the patient that you're not.
Yes. Yes. So. And A scan you'll have to do ultrasound because optical will not get you the results. Anesthesia, most of us do use local and plus minus a facial block. But in pediatric cases, uncooperative adults, in case of perforated corneas, general anesthesia was what generally recommended. IV mannitol really helps, and the maximum effect is in the 30 minutes. A lot of instruments are required, the defines, the RK marker, the scissors, and the rest of the instruments are generally from the cataract set. You can use those. Of course, you need the donor cornea, and as Quresh sir mentioned, a flaring ring does help sometimes. I like to use this kind of a screw speculum because I can help titrate my pressure on the eye with it. Coming to the donor sizing or the definition in case of pediatric cases, aphakia cases, and with peripheral anterior synechiae, I like to oversize my graph by 0.75 to 1 millimeters. In normal cases, I oversize by 0.25 to 0.5 millimeter, and in keratoconus, I generally go for the same size or oversize of 0.25 millimeter. Coming to the host sizing or the definition, depends on the host white to white. Generally, in cases of white to white less than 11.5 millimeter, I go for 7 to 7.75 millimeters of definition. Smaller in case of microophthalmos and larger in case of ophthalmos. So if the white to white is more than 12.5, then I would go for a larger definition such as 8.25 or 8.5. Of course, you need to look at the depth of the extent of the pathology and the size, cone in case of keratoconus, and you need to center it on the eye and not on the pupil. So coming to deciding the size, I like to mark I like to measure the white to white and then go half of it and then mark right in the center so that I get the center of the eye. Following which I measure the size of the opacity, and then I put ink marks on the side also, so that definition also it helps me guide in that time. RK marker, I prefer to use an 8 RK marker. This helps because I don't want too much smudging of the suture lines. AC management is very important over here. So this was a case where I did a 9 mm definition. This was a one-eyed patient. You need to cut with a side port knife and then try to be as vertical with the cuts into the cornea as much as possible. I like to refine my donor after this step. And then it's very important to be breaking these iridocorneal adhesions, and you need to be very gentle and very friable over here, because any rough handling or something can just get the whole the iris out. So over here you can see there's a PCR, pre-existing PCR, and there's a fibrous capsular bag. I trimmed this fibrous capsular bag. There was some vitreous prolapse, and I first cut it, the bag with the scissors, and then did an automated vitrectomy over here. I tried to center this pre-existing IL, but it was a little difficult. At the end, I had to explant it, and once explanted, you can see that this IL was completely broken. Then automated vitrectomy was again done, and this synecholysis is very important because to prevent, as Shivani will talk later regarding glaucoma management, it's very tough in such situations to manage them. So the next, I implanted a 3-piece IL over here in the sulcus, and you can see, and then pupilloplasty again, after which about which Dr. Fogla will be talking about. So this and then closure of the eye with the 4 cardinal sutures, and later on with the other 12 interrupted sutures, and then managing astigmatism with the keratoscope. In case of intraoperative bleeding, FND actually is recommended if you can do 15-20 days before this. I learned this from Fogla sir only, that you can give the cuts in the side of the blood vessels, and if the blood is coming to the center, it takes this blood away from the center. Covering the cataract management, sometimes it gets very difficult to do a rhexis, so you might have to cut the anterior lens capsule with this with your scissors, and then dial the lens after doing a hydrodissection. You might have to dial this lens out of position, and then I prefer to use a Simcoe cannula, and with the Simcoe cannula you can wash out this, and then implant the IOL in the bag. Sometimes it gets difficult to implant because there's a lot of positive pressure. In such case, you can put your sutures, 7 sutures, put the IOL, and then put the 8 suture. This rim is sometimes a problem if like I have not got a good cut over here, so this can induce a lot of astigmatism. So you need to trim this rim properly for better apposition. In cases where there is sometimes debulking also helps to get a good visualization, and then you can have a much more controlled entry into the anterior chamber. Dealing with aphakia or subluxated lenses, as you can see, this lens just popped out. There was the capsular bag was there. It was all damaged. I removed it, did a vitrectomy, and then did an esophageal implantation by MYX technique. And this patient also did well. This is another patient I just recently did. This is the post-operative day 1 picture with previously failed 2 grafts elsewhere. This was a PK with an esophageal. Coming to suturing, interrupted and continuous is what you can do. So you can either do a torque or an anti-torque or a no-torque suture. The ideal depth is for 90% that you would require, and you would have the distance from the junction, graft host junction, between 0.75 to 1 millimeters. The reasons for poor outcome would generally be the poor compliance, particularly in a country like India, the preoperative condition of the patient, or the preoperative BCVA, surgical reasons, and also the poor quality of tissue that is sometimes when you don't use it without evaluation of the endothelium. It is still being done in some centers in India. So for that. So to conclude, PK still has a very important role in today's scenario, particularly in a country like ours. Thank you so much. Any questions? Have Dr. Bhupesh next, who will be talking about complications, intraoperative complications.
एक सेकंड चल क्यों नहीं रिफ्रेश
कल रात को शुरू किया सर,
मेहनत की है लगता है।
पीपीटी नहीं चल रहा।
कहाँ चल रहा है अभी सुबह देख पड़ के
एक बार लैपटॉप बंद कर नहीं, वो स्विच मत करिए।
वेट अपडेटिंग माइक्रोसॉफ्ट ऑफिस प्लीज वेट अ मोमेंट तो विदाउट इंटरनेट अपडेट हो जाएगा
उसको हॉटस्पॉट दे दीजिए ना, हॉटस्पॉट से लेके और अपडेट हो जाएगा, कर देगा।
प्रोजेक्ट इट ना,
से यार इतनी जल्दी कैसे कर लेगा
प्रोजेक्ट
नहीं कुछ पंगा हुआ है इसमें अभी सुबह देख के आया अभी याद देखो दिखा रहा है कहाँ से होगा वाईफाई
एयरप्लेन मोड पे आपका।
एक सेकंड कहाँ पे नहीं है नोट पे चल गया Good morning everyone and thank you Karan for including me in this interesting instruction course, and this is a very interesting talk on intraoperative complications. And as surgeons we all face complications during our surgeries and we all have different techniques to manage these complications. So it will be better so that other panelists and faculties tell their way of managing these complications. We can discuss after the presentation. So intraoperative complications during keratoplasty are really reported primarily because most complicating occurrences are technical, and with proper training and meticulous attention to details can usually be avoided. Complications can be minor to vision threatening in keratoplasties. So start with the minor complication of scleral perforation. So I have seen a case where the surgeon was putting Fleringa ring and he perforated the sclera with the suture. So it's not that common, so we have to be very careful while applying the Fleringa ring, which is used in the ephikic and pediatric cases to avoid the scleral collapse. And if perforation occurs, so we have to finish the keratoplasty, and after that we have to examine the retina and do the necessary management. Improper trephination, we have seen many times that trephinations are eccentric, decentered, partial trephinations, but this is interesting that trephines got interchanged. The donor becomes the smaller and the recipient is bigger. And so if this happened, what has to be done? I don't have the idea a few years back, but now I know what to be done. So I had one case in which the trephine got interchanged, and so I removed the recipient part, and when I put the donor cornea, I found that something is not correct here. And it takes some time to understand that I have done the wrong trephination. And as in private practice, you don't have the backup cornea, so you have to deal with this cornea only. So I just tried my luck and put the tight sutures and with the bigger bites. We can how to forward this here. Yeah, the smaller 7.5 donor and 8 is recipient. 0.5 difference. So I put the tighter sutures and longer bites I took. The graft became almost flat. There was pooling on the cornea, you can see. So it was an old 80 years patient, pseudophakic. So otherwise I was normal. So this I become hyperopic. So now he don't require glasses for reading. So that's why he was very happy with the outcome. But definitely this can cause, and the take home message with this video is that responsibility of checking everything in the OT is yours, not your OT assistant. We always realize that give this, give that, and we don't check. So always at least check the trephine size while doing that things. So iris lens damage. So this also I have seen. So when you do the trephination without injecting viscoelastic in the antechamber, in thin cornea or in perforated cases, you can land up with some iris damage or some lens capsule damage. So it's always better to go for partial trephination, inject viscoelastic with the side port, and then complete the trephination so that we can avoid these complications. The next is the damaged donor button. I have not seen but heard that one patient ran away with the open globe. Once the recipient cornea was removed and patient was not uncomfortable during the surgery, and he get up from the bed and he ran away with the donor cornea on the thing, and then they checked, it was lying on the floor. Luckily it was the institute, so they had the backup cornea, so they replaced the cornea. But in prior practice, if something happened like that, you drop the cornea on the floor, then what has to be done? I think Muscati sir, Pula sir can give some insight on this situation. Eyes open and you have dropped the donor cornea, because you have to transport from side to on the patient's eye.
You have to open the conjunctiva, move it down, sort of Gunderson flap, and
Okay.
try and cover the.
Whatever cornea button you exercise,
Put that cornea.
The same cornea.
If it's still with you, that old cornea, put it back.
It's usually with us only, no? Yeah.
If that is not with you, then
And if it is on the floor, we should not clean it with the MK media and just put it in trial luck. No, out of question. Okay. So that's a take home point, because this.
put it in absolute alcohol.
Okay. So, but it will be, the endothelium will be gone. But that you have the yeah, you have the tectonic thing. Save, yeah,
Would take absolute alcohol, just dip it in that for maybe few minutes.
yeah.
Once you put in
Yeah.
absolute alcohol, it will be.
That is also an interesting suggestion. We can encounter this thing, we don't know. So retained Descemet's membrane, I personally saw 2 or 3 cases in last few years where once I started taking the donor cornea on the recipient, then I thought that something is not right. Why visco is not going down? Why it's not expanding iris? Then I checked, the full Descemet membrane was there. So it happens in pseudoaphakic bullous keratopathy cases, DM detachment cases. So we have to be very careful, see the iris structure carefully before putting the donor's cornea. The next is the posterior capsular damage. So incidence range from 4% to 16%. When we started learning keratoplasty or triple procedures, this was a very common thing. We mostly damage the lenses and then remove the lens, and it automatically comes out. But as you learn, these things goes down. But the idea is, once you have the PC rent and vitreous loss, do the complete vitrectomy. Don't leave vitreous in the anterior chamber, because if vitreous is touching the donor cornea, it is going to damage the contact area. And always do the PI, because pupillary block chances are very high in these cases. Anterior chamber hemorrhage, almost all cases of keratoplasty where any blood vessel is there, you are going to have the bleeding. Or sometimes normal cases also you saw bleeding, but usually they are temporary. Just put some epinephrine or just give the tamponade with viscoelastic, it settle down. But if it is still happening, then just close the eye, fill it with the viscoelastic, with the tamponade, it will automatically stop, nothing to worry. This is the most dreaded complication, and incidence is very low. It can happen in any surgery. Most common cases of ocular trauma, it can occur intraoperatively or postoperatively also. So literature has reported few cases in which most of the patient had hypertension and glaucoma, and almost all cases had previous ocular surgery. So if you're operating any case of keratoplasty in which already keratoplasty has been done, some trauma history is there, some lens drop is there, so chances are very high that you're going to land up in this. So we have to be very careful, and these are the risk factors mentioned in the literature. The ocular risk factors are previous surgeries, aphakia, glaucoma, high myopia, trauma, and choroidal sclerosis. So we have to be very careful, especially in the first 2, previous intraocular surgery and aphakia. So intraoperative risk factors are sudden increase in intraocular pressure, Valsalva maneuver, patient is holding his breath, intraoperative tachycardia. We have to monitor the parameters carefully. Not have much idea whether GA or LA is better in terms of choroidal hemorrhage. Maybe sir can tell. Is there any advantage of having GA in keratoplasty to avoid this complication?
GA prevents rise in blood pressure,
Blood pressure.
keeps the blood pressure more under control. So if you have any patient who's at risk of developing expulsive or choroidal, maybe doing it under GA gives you more control.
So GA is the thing, but although practice in India is LA, so we all practice keratoplasty in LA, but in abroad or outside India, everyone does under GA only. And this is a very important thing, that softening the eye before the surgery. Sometimes we don't give enough time to massage the eye or wait for the eye to settle down, and we just take the patient inside. And this is the problem that you land up with the choroidal expulsion. So tips in open sky is preoperative mannitol is must in all perforated eye cases, all large graft, repeat surgeries. Same technique again, don't refine fully in one go, to refine partially, inject viscoelastic, and then do the complete refine. Always use flaring in aphakic eyes because sudden collapse and deformation can cause the expulsive hemorrhage. So I have one video which I encountered 5 years back, and I will show this video. So this was the case, and once I removed the donor cornea, as soon as the cornea was removed, the lens was lying on the antivitreous phase, and I thought to cut the ledge, and during those 3-4 seconds, the complete content was coming out. This was new for me. I've never seen during fellowship, so I don't have any idea what is happening here. And neither my assistant had any idea what is happening. So they told doctors, "I'm bleeding ho rahi hai," and I was not sure what to be done. Then I remember that this is expulsive only. Then put the same graft, waited for some time. Luckily, it was not the very big expulsive. It was a controlled one. And I waited for some time. The blood was settled, and as donor was ready, so I just put the donor graft and thought of suturing it. And at the same time, intraoperative mannitol was also given to this patient. And once I was suturing the cornea, the pressure was so high that I was not able to suture. Sutures were breaking up. So I was clueless what to be done now, because we don't have.
Use thicker sutures.
Then my assistant told doctors, "I've used silk suture."
Not only thicker suture, what you can do is just the needle alone.
Yeah.
In my PK tray,
After this, I know that we have to 7-8 needles. Just put the needles.
not able just put needle in
Needles.
bottom
Yeah.
and just leave the needle there.
So after this incident, now I know that, yeah. Then I put the silk sutures 4-5, and then I waited, and then everything was settled. Then I replaced it with the normal sutures. So post-operative management is also very important in such cases. An IOP lowering should be there in the post-operative period. Long-standing hyphema can cause colon blood stirring, so you have to be judicious when to wash this blood from the antechamber. And long-standing kissing choroids can result in traction RD, so you have to settle that also, take the VR surgeon's opinion and plan accordingly. So intraoperative complications are the part of any surgery, but with the skills and alertness, they can be minimized and managed. Thank you.
So the expulsive, in my experience, once you see,
You know.
then that's the most feared complication every time
Yeah.
you do a
And after that, next 10-15 surgeries, I was so.
in my experience, all the risk factors here, but any sudden hypotony that happens intraoperatively
Yeah.
is more likely to cause expulsion.
Huh.
So if you're doing it like aphakics or vitrectomized eyes, always try to connect like a AC maintainer or a flow. Even if you have open sky, you should have some. You should not put flaring. You should not allow the pressure to become so low that you get an expulsion.
Yeah, AFX have some scleral collapse happens in those patients.
And I have a very low threshold for flaring herring, so I would use flaring herring very, very freely because it pulls the sclera
It's sufficiently good. True.
So is your savior, as he says, for high risk eyes, aphakic eyes especially, always put a
flaring
flaring
herring.
therapeutic, always put a flaring herring.
I've had a patient who I did a corneal decompensation, aphakic eye with, so we did a secondary R and a tube implant, and I said I'll do a DMEC later. Patient was perfectly fine day one. On the third day, he's seen by his local ophthalmologist with full choroidals because of the hypotony
Hypotony.
from the tube implant. The hypotony itself induced
Yeah.
kissing choroidals.
Yeah, post AGV is common to have choroidals.
These are things which you need to think
Yeah.
operatively and
So once you have complication, then you know the management for the next time. At least you're ready with that. Thank you so much. Thank you.
Start sharing it automatically. चल गया चल रहा है I think थोड़ा थोड़ा चल रहा है पसीना आ रहा है
acclimatize हो गया.
So,
थोड़ी देर में सर्दी भी लगने लग जाएगी.
So, good morning, everyone. After that wonderful talk about intraoperative complications, I have been given the topic by Karan to talk about postoperative management and complication in 6 minutes. So that I don't think I will be able to give justice to that, but yeah, I'll try. So, doing the penetrating keratoplasty surgically is a very important and very highly skilled surgery, but post-operative management is going to decide the fate of the graft. So that is also as important and very important for every cornea surgeon. So post-operative management actually changes with time. So in initial 24 hours, when you have just done the graft and you will be looking for wound integrity, you look for any loose sutures or leakage, and obviously you always have to be watch out for any infections which can happen in early and delayed and very late post-operative period as well. Early post-op IOP generally high because of OVD use or retained OVD or because of inflammation as well, and you need to control that with topical medications or systemic according to the IOP level. So this is generally the post-operative regimen, no financial interest, just to give you an idea that these are the medication we give in post-operative period, but depending on the indication of the keratoplasty, we would change our medication whether it is therapeutic or optical, stuff like that. In first 7 days, generally the reepithelialization of the donor cornea and the host epithelium grows over the donor, and that has to be checked. And if there is any delay in that, it also has to be, I mean, you need to look for the reasons why it is happening, like dry eye or any trichatic lashes, which is hampering the epithelialization. Inflammation control is very important because it will lead to high intraocular pressure, and it can also lead to graft failure as a secondary complication. Always watch out for infections and prevent and manage early complications, which I am going to talk about in the later part of the talk. And once the graft survives at least a month or so, then there is always a chance of having graft rejection. So you need to be careful with the examination. Always look at the endothelium site very carefully, because endothelial rejection is one of the most common we see in post PK and even post endothelial keratoplasty. It can happen. So in a late part, I think sir is going to talk, Hogla sir is going to talk about astigmatism and visual rehabilitation of the patient. So early post-operative complication is what we commonly see, especially while learning, when we are also learning, we say wound leak or wound displacement. So if it is associated with the shallow anterior chamber, it has to be resutured, and if there are loose sutures, and SE formation has to be done. If there is any iris prolapse, it also has to be taken in the OT. But if the SE is formed, there is a micro leak, you can manage it with the bandage contact lens or just a pressure patch. Persistent epithelial defect, it has to be, look for why it is not, the epithelium is not growing. There are multiple reasons why it can happen. So look for dry eye disease or limbus stem cell deficiency, which can be there pre-existing. And medical management involves profuse lubrication. And if it doesn't work, then you need to think about options like amniotic membrane or SLAC. If you have done a graft where previous history of herpetic keratitis is there, or you are suspecting a herpetic infection, then oral antiviral has to be given post-operatively, because that is also one of the most common reason for having a persistent epithelial defect. Any graft host junction abnormality, if your junction is not proper aligned, then obviously epithelium will not be able to grow, and that has to be surgically corrected. And any lead abnormalities like exposure or trichiasis has to be corrected surgically. Suture complications is also another issue we all face. Most commonly, sometimes the unrotated suture and not exposure, which can be just rotated on the slit lamp using a tying forceps. Any broken or loose suture, if the graft host junction or the healing and scarring has happened, you can just remove it, or it needs to be replaced with another suture. Suture infection is one of the most dangerous complication. I feel that it can completely just damage your graft, and you can the whole purpose of the penetrating keratoplasty can be into vein. And there are certain immune infiltrates we see in early postoperative period, which generally goes with time, and generally in immune infiltrates there is no epithelial defect associated with it. So the post-operative, this is one of my grafts which had very multiple loose sutures, and there was a graft infection with the corneal epithelial defect in that area. So all suture had to be removed, and the medication was changed. Post-operatively, steroids were stopped, and actually the graft survived, but the healing was there with the scarring. I'm not going to talk about post-op glaucoma management, which is going to be covered by Dr. Shivani. Inflammation is another reason where graft generally goes into rejection and ultimately fails. So inflammation has to be controlled with steroids, but steroid is always a double-edged sword, so it has to be used very carefully. So anterior synechia formation is also common in the periphery. If I had recently done a graft where the peripheral anterior synechia was exactly at the graft host junction, and that graft ultimately went into rejection. So that has to be taken care of intraoperatively. and posterior synechia formation leads to pupillary block and secondary high IOP and then glaucoma. I had a case where hyphema happened on the day 3rd, and I watched it, and then it happened again on day 5. I think Karan might remember, it was a case in Sitapur. So we did a systemic evaluation, and he had multiple liver related issues, and his blood profile was deranged, and that's how we came to know he was having recurrent hyphema. So this is the therapeutic graft where you can see the pupil is completely occluded, but I did I always do two surgical PA as taught to me by Dr. Karan, so it actually prevents any high intraocular pressure. And this is the graft where on the post-op day 1 there was a full, I put a air bubble in the anterior chamber, and there was it was okay. And the day 3 that was full chamber hyphema. So it has to be washed depending on the level of hyphema. Graft infection is a dreadful complication. So early graft infection can be because of donor contamination or suture related issues or incomplete excision of the host when you are doing for the therapeutic purpose. So certain risk factors which can happen, which can lead to graft infection is like told that persistent epithelial because of herpetic infection or prolonged use of BCL. Sometimes we forget to remove the BCL, so many times it happened. And patient has immunocompromised, then there is a high chance of acquiring any infection. So whenever graft infection is there, you need to stop or reduce the steroid. I would like to discuss that with our senior panelists here, that do you just stop the steroid when the graft infection happen, or just reduce it or switch to a low potency steroid. Meanwhile, we are getting the cultures and switching to other fortified medications depending on the organism we find. So this case I've been handling since March 2022, and initially she had a graft rejection which was managed, and after that she also had graft infection in the same eye. Some kind of capsaicin said fall in her eye, and then she had a ulceration in that area, which was managed medically. But you can see there was a healing with minimal scarring was there, but there was a thinning in the cornea in that area. So and primary graft failure. So when the primary graft failure happens, it generally requires either regraft, or you can just remove you can do a non-stripping DSEC also. So most common reason is pre-existing poor donor endothelium. Surgical trauma is also another cause, where if you are learning and you damage the endothelium while managing the tissue intraoperatively, that can also be the reason. So to prevent that, you generally want to use a more than 2000 endothelial cell count graft for optical purposes at least, and use generous OVD, especially with sodium hyaluronate and chondroitin sulfate. So graft rejection is a late complication. There are various risk factors which can lead to graft rejection, including younger patient, large graft, eccentric grafts, and if there is a more than 2 quadrants of corneal vascularization. Recently, there are reports of graft going into rejection after COVID vaccination. I think Sir has also shared his case of DMAC going into rejection, I think. So I would like to know Sir's views and other panelists' views.
I have seen after
Botox injection. That's new for me. So in Sitapur. Okay. So I still, there are articles, but we are yet to figure out why exactly still it happens. So this, whenever there is a graft rejection, the corneal thickness increases. That is you can, if you are doing OCT on a routine basis, which I do for my graft because of the availability, and you can see the corneal graft had increased thickness when it went into graft rejection. In the previous visit, it was only around 540. So graft rejection can happen just epithelial rejection or a stromal or endothelial rejection. Endothelial rejection is one of the most common we see in post-PK, and there is a typical finding there is a Cordadus line we see, and so for graft rejection, the steroid is the management. All form of steroid you can give, and cyclosporine is also debated role. I would like to know the views. So to conclude, for whenever you are managing a post-PK graft, close follow-up is very important initially. You have to watch out for infection and always balance the steroid use. And if graft rejection happens, it does not mean the graft has failed, so always fight for it. Thank you.
Just when you're using cyclosporine
Sir.
for graft rejection, the dose is the orosporin, which is 2%.
Okay, sir.
No commercial interest with Madurai group, but 2% is what you would use. If patient cannot tolerate it because of burning, stinging, you can dilute it to 1%. But the 0.05% is homeopathic. It doesn't work. It's good for dry eye patients, but not for grafts. For grafts, go for at least 2%. I mean 2% or at least 1% by diluting 1:1.
This is now available as sequelae 0.09%.
0.9 is again homeopathic. No, 0.5 and 0.9 is ज़्यादा फर्क नहीं. You need to go for 1% or 2%, which is huge, 100 times that.
Yes, sir.
Or taclimate, again, that's a Madurai product.
Good morning, everybody. Karan Bhatia's crash course on penetrating keratoplasty. He wants to cover every topic. The topic he had actually given me, and he had put 7 minutes on that. I don't think I am capable of finishing that in 7 minutes. So I'll just show you 3 surgical videos, and in that I will try to cover some of the points. This is a patient who had a hydrops where suturing was done, did not resolve, left behind with a scar in the visual axis. So we had to do a penetrating keratoplasty. The importance of flaring a ring has already been stated. I think for anybody starting out with penetrating keratoplasty and not doing penetrating keratoplasty too frequently, should always put a flaring ring when you're doing your keratoplasty. It not only supports, prevents the sclera from collapsing, it allows the eye to be centralized better. And in fact, you see that there's a speculum that's applied. It plays a very vital role when you're doing penetrating keratoplasty because the weight of the speculum, the way it's been applied, can, once you open the eye, it can create a lot of upthrust. So at least for me, even now I sometimes take lid sutures. 6-0 silk, take lid sutures, and that ensures that there is no pressing on the eye. And in fact, if you put a flaring ring, you can put your 6-0 proline, 6-0 silk through the flaring ring, and then that can lift up the globe. And that's very important in deep set eyes. Some of these eyes you will see, eyes are very deep. So there you can put in your flaring ring first, then put the silk suture and lift it up, and then you can even remove the speculum, and it keeps the eye globe very well centered, and you don't have a deep set eye. So in this case, if you see, we have gone ahead, put a flaring ring. When you pass the suture, I use a 8-0 or a 6-0 Vicryl, the needle should be visible when you are taking the bite, just like you do in strabismus surgery. It shouldn't be like, if you do that, you're more likely to have perforation. So apply at least 4 sutures, centration and sizing, everything Karan had already explained. Instead of just putting 1 mark in the center, I like putting these 2 marks, which are horizontal and vertical. You can put the 8 marks. In terms of trephination, I know we have all trained with handheld, but nothing like using a Baron suction trephine. Suction trephine gives you control over the trephination, centration is good, and you get a uniform cut all around rather than having an asymmetric cut where it is deeper on one side, shallow on the other side. So these trephines are freely available, so please go ahead, use that. Even for punching the tissue, use one of these donor punch from Catena, which have the 4 stabilizing pillars. Otherwise, handheld you do, again you have your donor slipping, you get punch out, one side you see the arcus or you see the sclera, and then you say, it's not been a, you try to achieve perfection. So when you're talking about achieving good visual outcome, these are important things that you need to look at. Again, once you have refined, don't go through and through. Do 95%, make a small entry, put some viscoelastic into the anterior chamber, which pushes the iris behind, and then you go ahead and ensure that you don't get a shelving cut. Try to be as parallel as possible so that you don't, the ledge may be useful initially when you want to rest your donor tissue does not fall. But ideally, if you want to have a proper graft host apposition, then the edge should be nearly vertical. Put in your donor graft and place the suture. Even while putting the suture, once you have the mark, you can initially put the 4 sutures, then ensure that the 4 sutures are symmetric. You get a nice diamond appearance, then put the remaining 4 sutures. I don't like to fill my chamber with viscoelastic. I always like to put an air bubble. The air bubble ensures that my handling of the tissue is gentle, because if not, every time you pass the suture, the air bubble keeps leaking out. But if you can do a surgery without air bubble leaking out, it helps improve your suturing technique as well. And because of the air bubble, the contour of the cornea is maintained, so you tend to end up having much better reflex with your keratometer at the end of surgery. Like in this, you will see it's almost looking, so this is something that you should do at the end of surgery to ensure that you are giving better refractive outcome to your patient.
So do you like to make a side port over here?
Yes, sometimes you can go through the side, or you can make a side port as well. So this is at day 1 post-op, and that is at 5-day post-op. You can see that the eye is very quiet and the graft is looking very good. If you are doing a triple procedure like this, in this case, so this patient has a scar, we remove the hypertrophic epithelium, and then we find that there is a lot of scar with vascularization, so a lamellar graft is not possible. Again, we go ahead, trephine. So here, instead of going through and through, what we do is we first debulk the cornea. We remove at least about 70-80% of the cornea. So I did the first lamellar dissection, and after that I found that it was still, so before I go ahead and do anything, I punch out my donor cornea, because I don't want to waste time once the eye is open to be punching out the donor cornea at that point. Then I go ahead, do the second layer of lamellar dissection, And now you see that my visibility of the anterior chamber is better. I put in some HPMC on the surface, go through a side port, and at least do the rexis. Because if I do open sky, then doing a rexis in open sky is sometimes very difficult, especially if there is upthrust. If I do a large rexis, the advantage is I can put my IOL in the bag. And if you put your IOL in the bag, you get a better IOL centration, less chance of posterior synechiae. So I think these are small things that you need to plan for when you're doing your surgery. Sometimes we have even done phacoemulsification if the visibility is good. So once you have done that, then you can open, but you will see that I don't open it completely. I like leaving at least one quadrant attached, so in case there is some severe upthrust or something, I can quickly close that by putting 2 sutures. Then you dial your nucleus out, remove the cortical matter, and then you can put in your intraocular lens. Again, putting an intraocular lens, what Karan pointed out is that if you have difficulty, you can always put in your graft, put 4 sutures, put in viscoelastic cohesive, then you can go and put in your IOL. Otherwise, in this process of putting in an IOL, when there is a lot of upthrust, sometimes you can break the posterior capsule. Again, rest of the suturing is the same. Once you have put, so you can see that I put 3 sutures, then I go ahead, cut out that remaining quadrant, and then place my sutures. So keeping a small ledge is always helpful, especially in pediatric cases as well, because there you will have sometimes so much of upthrust that you don't want to sacrifice your tissue for that. So you can quickly flip it over, close it back again. For doing combined secondary IOL fixation, it's important that you mark the axis first, because you need to know where exactly you're going to put your secondary IOL. Because once you have your eye open and then you try to figure out the 180 axis, it's very difficult. So we did a partial. Again, flaring ring is in place because vitrectomized eyes, pediatric eyes, eyes which are likely to have upthrust, these are cases where you definitely need to have. And even before I open the eye, I pass my needles into the AC. I'm using a 4-flange technique. So I put the 27 gauge needle with the Prolene suture into the eye, and then I go ahead and open because if you open the globe first and then try to pass the suture in a soft eye, it's very difficult. So here you can see that once I've done that, then I pull the Prolene suture out. Because in a formed eye, passing the suture is, the needle is much more easier. So once you have done that, you pull the sutures out, then you can cut out the remaining tissue. You can take the suture, I think the IOL part has just got messed up. Yeah. So you do your vitrectomy, then you take the PMMA lens, pass the suture through the hole in the haptic, do your cautery to ensure that you create a flange on both sides, and then the lens is placed into the eye, and then you create the external flange. So this is a very simple technique of fixing a secondary IOL when you are doing this surgery. So you can see that that's a heat cautery, both sides we have done. And then you can, that's the second flange on the haptic. Ensure that the flange is big enough, doesn't go out through then you can trim the excessive suture, and then you can just apply heat cautery. You need not finalize this step at this point of time, because if the eye is soft, you don't know how much of tension you're going to apply. So you can even either create just a flange and leave it, do the final trimming later, put in your graft, suture it, and then you can normalize the pressure, and then you can make the final adjustment of the flange for the IOL. Once you have done that, then you can put in your graft and complete the suturing. So I think the other option is that if you have an intact iris, a retro-iris fixation of the iris clip IOL is also a good choice, which is minimally manipulative when you are doing a triple procedure. So I think this is basically, I wanted to cover a few points. One is that the importance of lid suture, flaring a ring, not doing a complete refination, because not doing a complete refination, if you do like a 80-90% lamellar dissection, your visibility is better. You can manage your synechiae better without doing, because managing all this with the open globe is much more difficult. But if you have a formed chamber, you can go ahead do your pupilloplasty better without any upthrust, putting a lens into the eye. So I think these are few modifications that you can do which will help improve your visual outcome and reduce the risk of complication that you can encounter intraoperatively. Thanks for the patient here.
So I've been asked to talk about top tics while performing a pediatric keratoplasty. Sorry, bear with my bad throat. Do not have any relevant financial disclosure. If you look at, this child is around 10 months. So you have that classic blind look. The moment you restore visual access, you can actually see the visual behavior and the trajectory, the entire development, both sensory and motor in a child. It's so rewarding, that painstaking ability to perform keratoplasty in these children is really worth at the end of the day when you look at. And when it comes to pediatric keratoplasty, it is not simple miniature eye which we are dealing with, and there are numerous technical complications one would encounter. It is at least have been documented 10 folds higher technical complication one tend to encounter during the pediatric keratoplasty. So we need to have a very distinctly, all these factors are equally very important. To me, establishing diagnosis is the most important. As Karan said, some of the diagnoses have extremely good outcome and many of them do not have a good outcome. So the establishing diagnosis is a key which determines the anatomical success. And visual potential, it could be due to many other reasons. Apart from amblyopia, it could be vitreoretinal or even a CVI, certain other issues can directly impact. So this determines the functional success. You may have a clear graft, but child may not have a vision. So we should not end up in this particular scenario. And also assessing comorbidities, if they have a concurrent glaucoma, cataract, or any other vitreoretinal abnormality or a lens issues, this again affect directly the longevity of the graft. Any subsequent surgery is a big, hit on a graft. It may end up having trigger the rejection process or take away whatever that minimum number of endothelium present. So therefore, it directly affect the longevity. How long the graft survives is purely based on how clean the eye is. And most important factor, what we found out is social status, not necessarily economic status of the family. How committed family is for the rigorous post-operative care during the visual rehabilitative journey. The mother may be she may be uneducated, she may not have a financial freedom, she may have additional children, she has to take care, unless she has that organizational skill to instill, every hourly steroids in the initial phase is not easy. And also picking up, there are many complications one get to see, be it premature loosening of sutures, suture-related infections, or even a rejection, for instance. It has been documented 3/4 of the rejections are irreversible in a pediatric age group. So as my friends already have covered, explicitly very well what are all the preoperative determinant. In a pediatric, in addition, UBM is the key. This helps in actually accurately pinpointing your anatomical diagnosis. It's a mathematics now. You know the diagnosis, you would know the long-term clinical outcome and functional outcome. You can directly communicate to the patient. In some of those sclerocorneas, which are extremely poor prognosis, I'll be coming to shortly, we have a surrogate marker in terms of assessing the number of palisades per every square millimeter. This also add to the functional outcome. Apart from assessing the VEP, child visual behavior, and in a very rare circumstances, we may embark on a diagnostic endoscopy if you believe child has a vitreoretinal or optic nerve issues. And as I was talking, it's just not simple anatomical small configuration. Cornea is more pliable, and all of them need a technical modification. As some of my colleagues were covering, it should be hypotensive anesthesia, reverse Trendelenburg position, and wherever applicable, mannitol. Mannitol, I tend to give a bolus 1/3 and 2/3 is a slow, so that you would achieve that hypotony which is really needed. And of course, while applying a Fleuringer rings, one has to be extremely careful. Some of these scleras are extremely thin and vulnerable for a perforation. And one has to decompress extremely slowly, so has to minimize the suprachoroidal bleed. That can be a devastating complication. One of the important reasons for the expulsive hemorrhage is arteriosclerosis. He is hypertensive, people on some of the anticoagulant blood thinners. These are all the potential risk factor. If any patient had other eye expulsive hemorrhage, there is a 90% likelihood that we end up having expulsive hemorrhage. And in some of these cases, I do something called a sandwich technique. If the time permits, I can discuss with you offline. So the sandwich technique also minimizes the risk of lens touch and also some of the potential complications. Post-operative is equally important. And as I said, in these children, some of the sclerocorneas, within 4 weeks, we may have to remove all sutures. And as I said, resection is almost 3/4 of them are irreversible, and one has to be extremely careful. So is astigmatism. Just keeping the visual axis clear is inadequate. We have to give a appropriate optical correction and also institute amblyopia therapy. Although last 30 years, there have been an increasing result of pediatric keratoplasty. Otherwise, way before 1970, pediatric, PK, if you look at any textbook, it is contraindicated. And thanks to many of the pioneers, they have actually helped, achieve a good outcome even in these children. And these are the certain complications. And a long run, if you look at, so prognosis is abysmally poor for a certain cases. Something like a CHED in South India, which is much more commoner, tend to have a much better visual prognosis. Again, a repeat keratoplasties tend to have a poorer outcome. In a repeat keratoplasty, I do, institute, immunosuppression. I can talk about topical and systemic, outside this class if necessary. I'm just giving you one example, Karan. Maybe I'll take 2 more minutes. So this is a sclerocornea. You can see I've imaged this limbal palisades, and one of the thing is if we have a more than 5 palisades for every square millimeter, so that helps in maintaining the post-operative epithelial homeostasis and milieu. And cases which, so for instance, right eye didn't have a palisades. We could, measure only 1 or less than 1 inconsistently, and left eye had a 1 quadrant of limbal palisades, were more than 6. So I started with a left eye surgery, and this is a new technique which we are describing now, limbokeratoplasty. So what I essentially do is these cases which do not have a limbal palisades. This is a sclerocornea. They have a poor limbus, and entire cornea is filled with deep stromal vessels, and you have an extensive pus formation. One has to be very careful. And only modification I'm doing it, if you look at this donor tissue, these are less than 40-year-old having a 6-hour DPT and should have at least a 1 quadrant of a healthy limbus. And this is the histopathology, all high risk factor for a corneal grafting, including there are no endothelium here. And look at these children. They tend to do extremely well. It's very rewarding. And this child has completed 16 years of follow-up. And of course, we have to put them on immunosuppression. You can see post-operatively, I have put a specialized contact lens to minimize the suture-related complication. This child, in between visit, lost the torsorrhapy and a contact lens. In a 1 week, you can see a drastic difference between right and left eye. Okay. So even such cases, sclerocornea have a 100% failure at the end of 1 year. So with this new technique, we were able to achieve 10-year outcome about close to 80%. So I finish here and I'll go to directly. So as I said, early detection, correct diagnosis, and recognizing ocular or systemic comorbidities is a paramount in not only maximizing the success of the graft and also functional outcome. Imaging helps in pinpointing accurate diagnosis. One has to tailor-make surgical innovations, so help to achieve a good outcome in these cases. Sometimes it could be simple optical iridectomy, rotational graft, or a SEPA, and post-operative care is the most important than a corneal transplantation. So less with this new innovations and meticulous care will disprove the dogma which exists. The pediatric keratoplasty otherwise tend to have a bleak prognosis. So we can actually change that dogma, question it. Thank you so much, Karan.
Good morning. I would like to thank AIOS and Dr. Karan for giving me this opportunity. I will be talking about glaucoma management post-penetrating keratoplasty. So we know that post-PK glaucoma is a cause of irreversible visual loss and graft failure when our endothelial cell count is already low. There are difficulties in getting accurate tonometry readings, and the presence of media opacification makes the assessment of optic nerve and visual field further difficult. So if we have a smooth and regular graft surface, then Goldman applanation tonometry remains the gold standard, but this is not the case very often. So whenever we have irregular corneal surfaces, modalities like tonopin, dynamic contour tonometry, or rebound tonometry can help us get accurate IOP readings. It is just to emphasize here that corneas which have epithelial or stromal edema tend to give us inaccurately low intraocular pressure readings. A very nice article, review article by Dr. Tanuj Dada and his team. So talking about the mechanisms of this raised IOP after PK, there can be open angle or angle closure glaucoma. So in open angle, we have early onset and late onset cases. So early onset can be because of retained viscoelastic or hyphema, vitreous in anterior chamber. Late onset cases can be, the patient might be a pre-existing case of POAG, and steroid-induced glaucoma is a very common cause. In angle closure cases, pre-existing PAS, wound leak with further shallowing of anterior chamber can be the causes for early onset glaucoma. Pupillary block and malignant glaucoma can cause early onset or late onset rise in IOP. So progressive synechial angle closure after penetrating keratoplasty remains the main cause for angle closure glaucoma. So whenever the media permits, a gonioscopy is a must. A 55-year-old gentleman underwent therapeutic keratoplasty for corneal abscess here. We can see that the surgeon had to take a large graft. So this case somehow had higher IOP readings after the post-operative, on post-operative follow-ups. And the anterior segment OCT here shows that there is peripheral anterior synechy. So such kind of a picture is very common when PK is performed after suppurative keratitis or corneal perforations. The surgeon has to perform large trephination. So in that attempt, very often there is TM collapse, which makes the functioning of TM even bad. So for diagnosis of such cases, other than getting IOP readings and gonioscopy, we try to do the optic nerve evaluation after dilatation and take sequential disc photographs on follow-ups. In cases where we have a failed graft and the media is already hazy, UBM is really very helpful. It helps us to assess the angle and the extent of iridocorneal adhesions. Like we can see there is PAS in the image here. Talking about the management, prevention is better than cure. So intraoperatively, we can take care of certain factors like using an oversized donor button, performing sinucleolysis if we know that this patient already has pre-existing PAS, a thorough viscoelastic removal at the end of the surgery if it is used while performing PK, and a careful wound closure so that we do not come across further wound leak and AC shallowing. So this patient was taken up for cataract surgery months after therapeutic keratoplasty. We can see a gentle release of posterior synechy is being done here under high molecular weight OVD. And she also had PAS. So before proceeding for cataract removal, gentle sweeping of peripheral iris was done, and this patient did well in terms of IOP after this surgery. Post-operatively, judicious use of topical steroids helps us to control inflammation, prevent PAS formation, but yes, IOP monitoring is a must, keeping the possibility of steroid response in mind. Cycloplegics help us to keep the pupil mobile and reduce the chances of pupillary block glaucoma. Medical management remains the first line of treatment after PK as well. I am just highlighting the relevant side effects here. We know that beta blockers and alpha agonists are known to cause superficial punctate keratopathy. Carbonic anhydrase inhibitors can be used for short-term therapy in grafts, in good grafts which have a good endothelial reserve, but yes, on long-term therapy, they suppress the carbonic anhydrase enzyme in corneal endothelium and cause graft failure. Myotics are not recommended as they break the blood aqueous barrier and can cause graft rejection. They increase the chances of retinal detachment in aphakic eyes. On encountering steroid response, reducing the dose of steroid to the minimum required one, or switching on to low potency steroids, or substituting with cyclosporine really helps us bring down the steroid dose. In eyes which have clear grafts, open angles, and moderately elevated IOP and glaucoma medications, laser trabeculoplasty can be considered. If there is a component of pupillary block, laser iridotomy needs to be done. Conventional trabeculectomy has high risk of failure in the longer run because we know there are more chances of perilimbal scarring and fibrosis, especially in aphakic eyes. Glaucoma drainage devices have, they control glaucoma in a higher percentage of patients, like this case of mine who had uncontrolled IOP on maximum medication prior to the surgery, and after performing Ahmed glaucoma valve implantation, he did well in terms of IOP. But yes, the possibility of inflammation-induced graft rejection and tube graft touch, which can further reduce the endothelial cell count, has to be kept in mind. Lastly, in an attempt to reduce the aqueous production, cyclodestructive procedures can be considered, abiding by the time. Thank you. Yeah.
This session, I would request the speakers to please come on the stage for a photo. We can take the question answers outside if anybody wants, so that the other session can start.
No, no, no. Please, please.